Afternoon to everyone. I, Samriddhi Pednekar from the marketing team of Hetero Healthcare Main Division, welcome all esteemed doctors to this informative webinar. Today we are here to shed light on the topic influenza and its prevention and the potential role of molecule oseltamivir in pediatrics. And to discuss this, I would like to invite our first speaker, Dr. Pramod Jog, one of the eminent pediatrician, Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IAP 2016. So very good afternoon, sir.
Good afternoon.
Thank you very much for joining us. Also, I would like to invite our second speaker and a very renowned pediatrician from Pune again, Dr. Kevur Mahajan, MD Pediatrics, Pune, and Diploma in Pediatric Infectious Diseases, Oxford, UK. So, good afternoon, sir. So now I would like to hand over the session to Dr. Zog, and I sincerely extend my gratitude to all the participants here. And without any further delays, I would like to hand over the session to Dr. Zog. So over to you.
Thank you. I will just start sharing my screen so that our colleagues can see that. I hope the screen is visible.
Not full screen, sir.
1 minute. Is it full screen now?
Yes, sir.
Okay. Right. So, friends, today we will be discussing about influenza and its prevention. Now, you will be thinking as to why this particular topic has been chosen. And the reason is influenza is most common in our part in the season of monsoon. And all of you know that monsoon is in full swing in different parts. And I will tell you, these days, all the patients coming to the OPD, either they are vector-borne diseases related to the Aedes mosquito, and they are either dengue or in adults it is chikungunya, respiratory infections in the form of influenza or other respiratory viral infections, and then GI infections like gastroenteritis and typhoid. And I'm sure you will agree with me that the OPDs are very busy. And first of all, I must congratulate you to attend at this particular time, but I hope you have all finished your OPD, or at least it is coming under control. And we will discuss about influenza because it is quite relevant to this particular season. You will see that the nomenclature of the influenza virus, as you must have seen right from the 2009 pandemic, involves, just as I have put my name in that nomenclature, like, Z Pune 8 1958 PP. So it involves many different aspects of the virus, like what is the place from which the virus was isolated, what was the month when it was isolated, what was the year when it was isolated, and what is the name of the virus. Different names of this influenza virus are there, like H1N1, H3N2, etc. And of course, I was the president of IAP. So jokingly, I always say that I was the 2016 strain of IAP presidents in the Indian Academy of Pediatrics. So we are going to discuss some important aspects of this disease. And we'll start with an interesting case of a 3-year-old boy who came to me with fever, cold, cough, and progressive breathlessness over 3 days. Now, these days, whenever a child is brought to us for fever, cold, and cough, we usually know that this is viral, because whenever the onset is with runny nose or sneezing, then in the heart of my heart, I am, very happy that, okay, this is at least appearing viral to begin with in majority of the cases, because sneeze and wheeze, they are supposed to be viral in onset. Okay. But the most important thing is that this child progressively became breathless in the 3 days. And that was something worrying. He developed tachypnea. The saturation of oxygen was going down at room air, and the blood gases were showing acidosis. And this was the X-ray. And it was reported to have ARDS. And the child was obviously in respiratory distress. He was admitted to PICU. He was ventilated. And on admission, he was given oseltamivir along with supportive therapy. And he turned out to be H3N2 positive from the throat swab, and he was ventilated for 3 days, and then he improved. Okay, see, H3N2 is becoming rather more important than H1N1, and it is also turning out to be quite serious. And that's why you must know that different types of influenza viruses these days have different kind of severity. Now the question arises as to whether when this child came to me in the beginning with cough, cold, whether I could have started oseltamivir. Remember, oseltamivir is the antiviral drug which works best when it is given in the first 48 hours of influenza, that everybody knows. You should also know that oseltamivir works well even when it is started later in the course of the illness, and seriousness of the disease, the rate of hospitalization, both these are reduced by the use of oseltamivir. It's a neuraminidase inhibitor. I will tell you as to what is this neuraminidase. So there are many problems which you must be rather aware when you handle a child with cold and cough. Now, in this particular child who was previously healthy and came with cough, cold, and fever, and progressed over 3 days, whether the treating physician could have started oseltamivir by giving the this antiviral, whether he could have prevented this particular progression, and whether we should give oseltamivir upfront in the flu season. Okay, now the most important thing which I would clarify very much in the beginning is that when a child comes to you with headache, severe weakness, and pain in the muscles in the monsoon season, which is nothing but the influenza season, you are justified in giving oseltamivir, provided you find that the flu cases in the vicinity are in plenty. So that is something which you must know, and you need not wait for all that nasopharyngeal swab and PCR, because at peripheral places, getting a PCR and a nasopharyngeal swab is like a dream, isn't it? And that's why, in case if you have a strong suspicion, if the child is not really looking well, then you are fully justified in giving oseltamivir, and CDC also has supported this particular view. So there are some confusing points as they are related to flu. I have put them as confusing points. So the question is, when a child comes to you, whether it is bacterial or viral. Okay, all of us know that viral infections are usually generalized, meaning thereby in the respiratory system itself, they will produce, as I told you, sneeze and wheeze. The same child will have runny nose, the same child will have red throat, the same child, when he has respiratory syncytial virus, has crepitations when he gets bronchiolitis and so on. While bacterial infections in general are localized. So if a child gets streptococcal infection of the throat, he will only get streptococcal throat infection with follicular tonsillitis. That child will not get pneumonia. Or if a child who gets streptococcus pneumonia infection will get, say, pneumonia, but his throat may not show you follicular tonsillitis. So the infections which are bacterial are in general localized. Secondly, a child who has viral infection when he receives paracetamol, usually in the interfebrile period, that means you give paracetamol and then the fever comes down, then usually the child appears normal in the interfebrile period. While a child who has bacterial infection, even after the fever comes down, looks dull, and mother says he doesn't appear to be the usual self. Otherwise, when the fever comes down, he will start fighting with the elder brother, and a lot of danga masti will be done by that child. So that particular thing is not there. And within the family, whenever there is a viral infection in a child, the other members in the family also will be involved. So more than one member in the family will be involved. Now, why this is important? Because if a child gets flu, then those who are in the family are likely to be at a higher risk. For example, the father is diabetic, the mother is pregnant, the grandfather is asthmatic, and the grandmother is obese. So everybody has some risk factor or the other. And remember, flu is very dangerous in those who are having some risk factor. Okay, so remember, there are quite a few risk factors, and you should be very careful. When you suspect influenza in a child, you should avoid spread of influenza from child to others in the family. Okay, and of course, I always say that to find out the type of the virus which has affected the child is extremely difficult. And we know that Rajnikant, the famous South Indian film star, can do anything. Okay, but I am sure even he will not be able to diagnose whether it is a rhinovirus or adenovirus or influenza virus. Okay, of course, I am just telling it jokingly. The point is, there are some indicators which I will tell you in a minute as to whether you can, at least come closer to some diagnosis clinically. And then, as I was trying to tell you, the seriousness of H1N1 and H3N2 may be different, and you should all remember to find out whether I should start oseltamivir upfront. Now, this particular decision may not be that easy, but then your intuition, your sixth sense, your experience will come to your help, particularly in a scenario when lot many influenza cases are there in the community, in a season like rainy season, and someone else in the family is, say, either H1N1 or H3N2 positive. Okay, so remember, when you say it is viral, now I will tell you, quite a few times, these days, young children, 5, 6 year old, they come. Recently, a child came to me with a doll in the hand, and the girl was continuously talking to the doll. And when I examined this particular small little girl, she was speaking to her doll and telling her, "Don't worry, it is viral, viral." But when she was saying, "Don't worry," I was relatively, shaky, because viral infections have these days not remained, so simple. Okay, because we know that, say, for example, adenovirus, it is showing prolonged picture. The child is getting fever for 8 days, 10 days, even 15, 16 days. It is coming with, different kinds of presentations which mimic bacterial infections. The CRP is high, the WBC count is high, the picture on the X-ray is like lobar pneumonia. So it simply, for the namesake, it has remained adenovirus, but in fact, as I will tell you, it is behaving like a bad adenovirus. The adenovirus has become really bad. Okay, RSV also, it is okay. Many times we are not bothered if a child is very healthy. It comes and goes, but in certain cases, it can become rather serious, and so on and so forth. So after COVID, we have witnessed different viruses and the waves, like the respiratory syncytial virus wave came, the hand, foot, mouth disease viral infection wave came. Then we have this adenovirus going on for 1 or 2 years now, and even older children are getting affected. And in the OPD, there are either cases of recurrent respiratory infections or otitis media. See, otitis media over years actually had gone down, but over last few months, and maybe for 1.5 or 2 years, the incidence is showing a rise. Adenoidal hypertrophy, then unseasonal surge in influenza. We say influenza comes in monsoon, but even in other seasons, influenza is coming up. As I told you, adenoviruses, which are acting as bad adenoviruses, with varied presentations and prolonged illness. And as I told you, when the CBC is high and the CRP is high, we have a diagnostic dilemma. And many times we have to resort to the nasopharyngeal swab. And many times it's a dilemma, a confusion whether I should start antibiotics along with antiviral agents, and what do I do about those metered dose inhalers and nasal steroids. So the use of all these medications has definitely increased in the OPD over last 1 or 2 years. And why I'm trying to put this picture in front of you is just to explain the background before we see certain important cases. So let us start with a case. I will just tell you that the name of this child in the case will have some close relation to the diagnosis. So Viru, I will just tell you that this child had fever for 3 days with cold and cough. He was on metered dose inhaler for a wheezing disorder, and he was well controlled on that. He was receiving symptomatic treatment, and he came back after 3 days and again became afebrile for a day, and again got a fever. In between the episodes, he was quite active. The parents were obviously worried, and they asked me, "Dr. Jog, what is this going on? He's getting sick repeatedly." Obviously, this is a case of recurrent viral infection. As I told you, they have become more frequent. They have started coming at a shorter interval, and obviously we are not going to antibiotics because we are convinced that they are viral. Now, how to counsel the parents in such a situation? What I would suggest is that tell the parents that if a child is getting repeated viral infections, it is not something wrong. A normal child in a year gets about 8 to 10 viral upper respiratory infections. Number two, the child has recently started going to the preschool, And other children who are having viral upper respiratory infections are donating the virus to your child. Number 3, the child has not developed any immunity during the COVID period. So he is now likely to get exposed to the viruses against which he doesn't have immunity, and that's why he is likely to have these infections. So on your own, you can just tell them. I many times tell them that, see, that the child is developing fever is a good thing, because development of fever indicates presence of good immunity. See, if a child is malnourished, if a child has immunocompromised state, he may not get fever. So in fact, I tell them that, in case if your child is getting fever, be happy. Of course, some of them, they look to me with little suspicion whether Dr. Jog is telling just something for the sake of telling. But remember, this is the fact that if a child has good immunity, then only he will develop fever. But if it doesn't develop fever, it means that the immunity is deficient. Anyway, so you can use some of your counseling skills to counsel the parents, and you must know that the pharyngotonsillitis in majority of the cases, 60 to 70% cases, is viral. So it is either rhinovirus or influenza or parainfluenza, RSV, adeno, entero, or Epstein-Barr or herpes simplex. So some of these viruses are the ones which produce pharyngotonsillitis, which can produce red throat, and that is why red throat is not an indication for giving antibiotics. It is the follicular tonsillitis with tender cervical adenopathy, with high fever. That is where you can probably think of giving some empirical antibiotic therapy. And there are different scoring systems, to guide you whether it is viral or bacterial. Obviously, 30% of the bacterial infections affecting the throat are related to the group A beta hemolytic streptococcus. And you should also know that pneumococcus and Hib, if they are isolated from throat swab, they are colonizers and not the pathogens. Okay. Now, is it possible to identify the enemy? So, if it's a child who comes to you with cold and sneezing, it's a rhinovirus, where it's simple common cold, where upper airway has been involved, the fever is very mild or no fever, there is no exhaustion, the child is playing well. Okay. As I told you, influenza will come with severe headache, weakness, and muscle pain. RSV will come with bronchiolitis in children, particularly under the age of 1 year. I told you the presentation of adenovirus could be with pharyngoconjunctival fever, diarrhea, mesenteric lymphadenitis, or hemorrhagic cystitis. And the bacteria, as I told you, fever with follicular tonsillitis with tender cervical node, indicative of streptococcal infection. Fever, grunting with tachypnea, indicative of pneumococcus. Rapid progression in a toxic child, indicative of staph. And child who is above 5 years getting predominant cough has likely to be a mycoplasma infection. So let us see some other cases which came to my clinic recently. So he's a 4-year-old child with cough, fever, high grade for the last 5 days. As he was having high grade fever, we were worried. And even the paracetamol given for 2 days, 3 days, 4 days was not helping. And he was not settling with oral medicines at all. But on admission, he developed tachypnea and he needed oxygen support. Obviously, he was not in a good shape. With all the medical treatment given, we investigated the child, and he had a WBC count which was 1620. That is basically a low WBC count. You can see the platelet count was 1,32,000. So the platelets were low, and the SGPT and SGOT were on the higher side. And the nasopharyngeal aspirate which was done was positive for H3N2. So this was a case of influenza where the WBC count and the platelet count were on the lower side. Now look at this particular important scenario wherein you will find that influenza can produce some of this particular change in the blood picture. Another H3N2 child where he was 3-year-old with cough and fever for 5 days. Fever was not settling, but the counts were normal. And the nasopharyngeal swab showed H3N2, where we had to give oseltamivir. Another child with H3N2, again 5-year-old child, I am showing the X-rays by the side, where the child had cough, cold, and fever. The counts were normal, but the CRP was 38. And that's why you must remember that, in influenza, you might get high CRP, just as I told you about adenovirus. And the nasopharyngeal aspirate showed H3N2. Being in Pune, we are relatively lucky to have, access to these nasopharyngeal swabs, but otherwise it comes to simple clinical diagnosis. And this particular child, who was 4-year-old with cough and cold for 5 days, with high WBC count and high CRP, we thought that this is definitely bacterial. In fact, some of our colleague had started with ceftriaxone, but he continued to have high fever. And after 5 days, when we did the nasopharyngeal swab, it showed adenovirus positivity. Okay. Now, this child, Ria, she was a 5-year-old girl with high fever for 5 days, with cough and cold for 5 days. She was looking sick. Okay. She had mild wheeze, but no crepitations. Okay. And for all particular reasons, she had only upper respiratory symptoms. Okay. And along with mild wheeze. Now, the point is whether we give antibiotics in such a child, because many times, parents from an educated family, they want to know, as to Dr. Joe, it's okay, you are speaking about all this, but then what to do? The child is really sick. So this child was put on, amoxiclav, but WBC count was on the lower side, 2800. The neutrophils were only 10 and CRP was 34.7. And obviously, this particular child being sick, the child was, put on this amoxiclav along with oseltamivir, thinking that it is likely to be additional flu infection. However, the nasopharyngeal swab showed rhinovirus. Okay. So, the clinical presentation was something else, but the nasopharyngeal swab was showing this rhinovirus. Many times this virus is an innocent bystander. It doesn't produce much of a problem, as I told you in the beginning. So we should also discuss about the sensitivity of influenza PCR and the treatment decisions, whether we can base our treatment decisions simply on influenza PCR. Okay. And then Flora was a 7-year-old daughter of an IT sector parent. Remember, IT sector parents are information technology parents, very, very intelligent. But at the same time, IT stands for inquisitive and troublesome. Okay. So they will have hundreds of questions. And this child had high fever for 3 days with throat irritation, and examination was there after 2 days. Parents were worried. They say, Dr. Jog, you are looking at the throat, which is showing mild congestion. You have started with paracetamol, that's fine. But outside, it's flu and adeno going on. So what do I do for this particular child? Now here, please remember that whenever a child is brought like this, you have to go for CBC, CRP, throat swab. And many times, in case if you find that the child is really unwell and there is flu season outside, you can always put them on empiric oseltamivir if required. Okay. And then Tejas was a 3-year-old boy who came for cough for 1 week, high fever for 3 days, crepitations. The child was put on co-amoxiclav and admitted for persistent fever. Even after a week, this child was continuously coughing and he had high fever. Okay. Now, he was put on intravenous amoxiclav. The WBC count was 7,750. Neutrophils were 49. CRP was normal. And the swab showed influenza A. And then oseltamivir was added. Now, the question here is, when you put the child on antivirals, whether you stop antibiotics, okay? And some of these decisions are really difficult, and we will discuss it in our, post presentation discussion, okay? So now for this particular child today morning, the younger sib, 8-month-old, has come with high fever since yesterday. And now you are thinking as to what to do. But if there is a contact with the child with influenza A positivity, then you are fully justified in giving the therapy to the child in the family who could be the brother or a sister, because as I told you, viral infections in more than 1 or 2 members in the family are going to be the same virus. Okay. Now, remember that influenza is a very naughty virus. It changes every year. And that's why the bank, as the bank asks for our KYC, know your customer, they would like our Aadhaar card and PAN card. Similarly, every year we have to ask the Aadhaar card and the PAN card of the influenza virus. Okay. So it's an RNA virus, and RNA viruses are known to change their structure. COVID virus also is an RNA virus, and we know how it changed the structure between 2020, 21, 22. And remember, there have been 4 major global pandemics from 1918, 1957, 1967, 2009, and these were all related to the major shift in the structure of influenza virus. Okay. Remember, we many times feel that influenza is during monsoon, but influenza is also now showing viral infections rather going on all throughout the year, and there has been a huge surge in the flu cases. And we must remember that in certain parts of the country, the epidemiology is different. This is a study from Tamil Nadu, which is a 7-year-old study done in the Department of Virology at the King Institute of Preventive Medicine. And there were almost 37,000 specimens which were subjected to influenza, and the duration was 7 years. And the influenza positivity started with the onset of monsoon and peaked during the post-monsoon months. That was the finding. Okay. And you should know that this virus is basically is a highly contagious airborne disease which occurs in epidemics and manifests as an acute febrile illness. Many children come to you with shivering. Now, I will tell you, these days when a child comes to you with fever and shivering, there are 2 or 3 different things. One is, if the child is little older and complains of pain in the legs and back pain, headache, retroorbital pain, obviously, if the child doesn't have cold and cough, we usually start thinking in the terms of dengue or dengue-like illness. If he has cold and cough with fever with chills, please start thinking of influenza. And remember, influenza, serious outcomes of flu infection can result in hospitalization and even death. Okay, it's a very, very common infectious disease, and you must keep it at the back of mind as a suspicion. There are 3 types. Type A is the one which is responsible for epidemics. There are minor changes in the outer, hemagglutinin and neuraminidase glycoproteins. Every year, the amino acid sequence changes. So, Pramod becomes Vinod in 2025. Okay. In 2027, it becomes Amod, like that. So, it's a minor change. But certain periods when the virus, influenza virus from the birds, influenza virus from the human beings, both of them, they get into a pig, and the pig acts as a mixing vessel. At that time, the pig will start showing a different kind of a virus by mixing of the different viruses, and suddenly a new virus will come which will produce a pandemic. Okay, this is a major change, major antigenic variation. Okay, so Pramod will suddenly become Keyur. So that's a total change. Okay, and that occurs once in a while. And as I told you, there have been 4 major pandemics. So influenza B virus infects only human beings and doesn't produce major, pandemics. Okay, so just remember that currently H1N1 and H3N2 are the main influenza viruses circulating in the community. And when a person is there up to about 6 feet from you, he can get infected with this particular virus from you. And that is why you have to keep a person at a hand's distance. Usually, we know that 3 feet are there, including your body and the hand which is stretched outside, it is 3 feet. So 3 feet from your side and 3 feet from the other person's side makes total 6 feet. And the droplets, they can land in the mouth or the nose of the people who are in front of you, and they are inhaled into the lungs. And remember that children, they pass on the virus longer than 7 days. And the infectivity begins 1 day before the symptoms and up to 5 to 7 days after becoming sick. So already when the child has cold and cough, he has started becoming infective. And there are certain diseases or the spectrum of diseases like ILI, that is influenza-like illness, H3N2, SARI, that is severe acute respiratory infection, and COVID-19. This is only for you to compare. Most of these, as I told you, have a similar presentation where there is fever, myalgia, cough, weakness, sore throat, and if they become serious, the child may become breathless. Headache is present in some of them. But remember, H3N2, that is flu, headache is almost always there. Okay. And categorization of these influenza-like illnesses has been done. And in children, you have to be very, very careful when there are certain signs like fast breathing or bluish skin color. The child is not drinking enough fluids, not waking up, not interacting, and is so irritable that the child does not want to be picked up. And that's why you should remember that these are some of the signs which should be told, rather symptoms, to the parents when they come to you and when they go back. So they have come to you today on 12th of August. You have given them consultation. As a good pediatrician, you have not started antibiotics, but you have not started even antivirals. You have given only paracetamol. Tell them 1, 2, 3, 4, 5. If these things happen, then please report to me. Okay. Then in that case, you might have to start oseltamivir. Okay. Dengue, for example, we tell them the danger signs. If the child has headache, if the child has chest pain, breathlessness, pain in abdomen, nausea, vomiting, then you please report to me. So like that, you must inform them when they come to you. Okay. And remember that the complications of flu are also to be remembered, particularly, ARI, then acute otitis media, absenteeism, and antibiotic abuse. In case if a pediatrician is unable to differentiate viral from bacterial, then obviously, he starts antibiotics, and that's the antibiotic abuse. So please remember that you have to be very, very careful. I told you in the beginning, the first case that I told you had ARDS. That was nothing but a severe complication wherein, the gaseous exchange was hampered. So otitis media is one of the important complications, occurs 1 to 4 days after the onset of influenza symptoms. Pneumonia, which could be primary viral, or there could be secondary infection because of Streptococcus pneumonia or Staph aureus. And some children, particularly those who have chronic problem like asthma, okay, there, that could be exacerbated. And in few children, this particular virus can lead to respiratory failure or acute laryngotracheobronchitis. I will just tell you, this case got admitted under my care. 6-year-old child with cough, cold, and fever with respiratory distress, had cardiac, hepatic, lung involvement, rapidly progressed, and was on high frequency ventilator. This is the child, and he was admitted and turned out to be influenza B positive. Okay. Along with that, of course, there was Haemophilus influenzae also, which was detected. And some children can have toxic shock syndrome, or some of them might have cardiac involvement, which can lead to myocarditis. And this was the child who was 1 year old with fever, cough, cold, status epilepticus, nasopharyngeal aspirate showing H3 and 2. The counts were normal. And as the child was in status epilepticus, MRI was done, which was showing non-specific encephalitis changes. CSF was normal, but this was influenza encephalitis. Remember, the neurologic complications of influenza are in the form of simple febrile convulsion or influenza associated encephalopathy due to cytokine dysregulation, acute necrotizing encephalitis, which has also been reported from many centers, Guillain-Barré syndrome, and aseptic meningitis. So another complication is myositis, particularly with influenza B. A child between 6 to 9 years, particularly boy, has bilateral gastrocnemius and soleus involvement. You must have seen in the OPD, they say a lot of, pain in the calf muscles, okay, and inability to walk. Even the parents have to lift this particular child. In an older child also, even an older child needs to be lifted up, okay. And in my residency days, we used to see those Rye syndrome cases, particularly, in a child who has influenza B. In case if he is given aspirin salicylates, then he can land up into liver cell failure. Now, we should know as to how to manage influenza, and it's not at all difficult. For the mild cases, we all know that we give bed rest, give extra fluids, cough suppressants, antibiotics, and control of fever and myalgia with the help of non-steroidal anti-inflammatory drugs, and children usually recover in 3 days. Severe cases may require IV fluids and other supportive measures. But the most important thing which I want you all to know is about the antiviral drugs. And neuraminidase inhibitors, I told you that there are 2 glycoproteins outside on the influenza virus, outside. Hemagglutinin is the one which is responsible for attachment to the respiratory epithelium. The virus attaches itself with hemagglutinin to the respiratory epithelium, and neuraminidase enzyme is critical in releasing the viral particles from the infected host cells. Okay, so when this particular virus is transmitting the viral particles from one cell to other, when you block the neuraminidase by giving oseltamivir, which is nothing but an antiviral agent, neuraminidase inhibitor, the spread of the virus from one respiratory epithelial cell to other is halted. Of course, the severity is reduced and the chances for hospitalization are less. Okay. Now, remember, this oseltamivir is a potent and a selective inhibitor of the neuraminidase enzyme, and in the body, basically it is converted to an active form called oseltamivir carboxylate, and it inhibits influenza virus replication and pathogenicity and further spread of infection. It is effective against all the influenza A and B viruses, including the avian H5N1, swine H1N1, and H9N2 strains. And it was the first oral neuraminidase inhibitor approved in more than 100 countries now. And this is very important that you know the dosage schedule. Adults, it's very simple. It's 75 milligram capsule twice daily as a therapy and 75 milligrams capsule once daily for 10 days as chemoprophylaxis. In children, the dose depends on the weight. So, under the age of 15, it is 60 milligrams per day divided into two doses. That means 30 milligram capsule in the morning, 30 milligram capsule in the evening. Okay, this is therapeutic dose. Fortunately, we have a 30 milligram capsule available in the market, and that's why please use one in the morning, one in the evening. It's very convenient and saves the cost also. For therapy, this is twice daily dosing, but for prophylaxis, it is 30 milligram only once daily. Okay, and if it is to be given in the form of a syrup, remember 1 ml of syrup contains 12 milligrams of oseltamivir. So we can give 2.5 ml, which is equal to 30 milligrams. Depending on the weight, between 15 to 23 kilograms, 22 to 40, and for more than 40, the dosage increases. And under the age of 1 year, the dose is 3 mg per kg twice daily as therapy. And chemoprophylaxis is not advocated under the age of 1 year. Remember that treatment with oseltamivir should be initiated within 48 hours of the onset of the symptoms. Okay. And as I told you, 30 milligram capsule is very, very convenient for children who are weighing 15 kilogram or less. The treatment dosage is for 5 days, 30 milligrams in the morning, 30 in the evening, and prophylactic dose is for 10 days, 30 milligrams only once daily. Okay. So it gives dosage convenience, no wastage, and it is quite pocket friendly because the entire course costs less. Okay, there have been quite a few benefits of the empiric and the early use of oseltamivir, which has been proved by clinical trials under different situations. And remember that patients with a shorter time to oseltamivir administration were discharged earlier from the hospital. And even WHO has recommended that empiric therapy is necessary and treatment could be started as soon as possible. Lab confirmation of the virus is not necessary, and the negative lab test for H1N1 does not exclude the diagnosis. Therefore, you have to start giving treatment early. And if high risk individuals have been exposed, like as I told you, the OBs, the ones who are above 65, the ones who have some cardiac or respiratory problem or immunodeficient, then consider presumptive therapy with oseltamivir. And you must remember that anti-influenza therapy like oseltamivir is prescribed for even adults with community-acquired pneumonia who test positive for influenza. And oseltamivir is associated with reduced risk of death in patients for community-acquired pneumonia who test positive for influenza virus. And treatment within 2 days of symptom onset or hospitalization results in better outcomes. So how do we proceed in a given child? Remember, if the PCR is positive, remember, then antibiotics are either not to be given, or in case if you have started, you better stop it, but at least don't escalate. That means if a child has continuous fever and you have put him on amoxicillin, you either can stop amoxicillin when you find that PCR is positive, or at least do not go on from amoxicillin to amoxiclav. Okay. And remember that flu vaccine, basically, it is to be given because the need is definitely there. The efficacy depends on the matching of this particular virus with the virus circulating in the atmosphere. It is quite safe and cost effective, affordable, and we give 2 doses at the age of 6 months and 7 months. And depending on the epidemiology, it is better to give this vaccine in the pre-monsoon period, particularly in majority of the parts of our country, so that the child gets protection during the monsoon. Okay. And remember, the principle that I tell my friends is happy birthday to flu. We all say that happy birthday to you. But then, this shot, after the initial 2 shots given to a child or an adult, next year, every year, we have to have this as a single dose. And which better day would be there to remember than our happy birthday? So when you cut the cake on your happy birthday, also ask someone to give you a prick also, so that you get, this influenza vaccine. Okay. So remember that this virus is a fast and a furious virus. And this is because it's very, very abrupt in onset. It comes suddenly. The child was fine today morning, but suddenly in the evening, the child is having fever with chills, headache, and weakness and muscle pain. the transmission is very high. The other child in the family suddenly becomes unwell. The progression is rapid, as I told you in the first case. Within 3 days, has become breathless. May develop complications like ARDS very fast, and the child, as in my residence terms, gets vertical discharge. That is, mortality is very high, and then oseltamivir has to be given within 48 hours. So in this virus, everything is fast. You don't have time to wait, and that's why, along with the SMS, that is sanitization, mask, and safe distancing, you have to follow cough etiquettes. Also, remember to have the Hasta Panchasutri. Wash the hands, do handshaking in very, very limited conditions, but not at all. It is the avoidance of handshaking and namaste, which is better. But then handkerchief use, keeping other person at a hand's distance, and avoiding hand touching. Remember, with this, I will just say namaste to you. I already told you to keep other person at 6 feet distance. He may think as to why is it so, because in Pune, the place where I am there, usually people keep other person as it is, even without influenza, at a 6 feet distance. But particularly for influenza, they always will remember to keep the other person at a 6 feet distance. Anyway, I remember of patients who even wanted me to keep them away from them by 6 feet. I told them, at least let me examine the child. But they said, no, you might have been infected, then our child also will get infected. So there are Punekars like this also, but doesn't matter. I always used to then use a mask so that the infection is not transmitted. Anyway, with that, I thank you for a patient listening. And you must take care, because flu ends with U. The last alphabet of flu is U, and that is why, please remember that in a particular child, when it comes to you, you have to be very, 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 very careful, because you yourself could be also high risk, and then the child may infect you also. And that's why you better use a mask, and yourself also please take annual influenza vaccination. So with that, I will stop sharing my screen, and thank you for a patient listening. So Keyur, is my screen has the sharing stopped from my side?
Uh,
Can you see the slides?
no, we can't see
Okay.
slides. It is just blank
Okay,
screen.
very good. But I can see you now. That's wonderful. So now, Keyur, as an infectious disease specialist, I have certain things which I would like you to respond to. And of course, before that, if you want to speak anything on your own, please feel free to give your comments, so that all of us will benefit from your knowledge and experience.
Thank you very much for inviting me. But sir, you have already covered such a nicely topic in every and each aspect in prevention, medicine, and you have covered so many cases. You have covered so many case scenarios also. So I think I cannot add much whatever you have given knowledge to the people. So if any queries, questions, or any
Actually,
scenario.
Keyur, what I was trying to say is, during the flow of my talk, I was referring to those, nasopharyngeal swab reports, okay, like H1N1, H3N2, adeno, and all. Now, in one of the cases where I suspected that this is likely to be influenza, but it turned out to be rhinovirus, okay. And then at the end, I had just posed a question saying, what is the sensitivity of PCR, particularly when it is influenza? That means the child definitely has influenza, but it has turned out something else. Okay. So just for the information of our listeners, just tell them as to what is the inference to be drawn when a child coming to us for cold and cough and fever, when he's subjected to, say, this nasopharyngeal swab examination, and suppose examination shows these 1, 2, 3, 4, 5 viruses, then it is most likely that they are the ones which are pathogenic, while these 1, 2, 3, 4 viruses, when they are seen, they are not pathogenic, and one should not worry. And as to particularly for influenza, what is the likely sensitivity? That means, if if you could elaborate, then this is something which our colleagues probably would like to know from you.
Sure, sir. So the sensitivity and specificity will depend on the pretest probability also. So what is the possibility of having influenza infection in this patient? Okay, so any test before ordering, you should be very sure in your mind that this child may be having influenza. Ordering influenza test when there is no influenza epidemic or epidemiology is not there. When in those scenarios, if you order, see, if you order influenza in June, July, August, when the flu season is going on, the pre-test probability of coming that test positive is more. But if you see, if you order in dry season, like in Feb, March, April, when the influenza epidemic is not going on, that the pre-test probability decreases. Okay. So overall, the also second thing which matters is how the swab is collected. If it is collected properly, if it is collected from the nasopharynx, postpharyngeal wall, so how the collected swab is collected. So depending on all these scenarios also, so overall the sensitivity of influenza test is 70 to 90%, depending on the techniques used and how the swab is collected. Okay, specificity is 80 to 100%. Okay, so definitely the PCR test, nasopharyngeal swabs are good tests because in COVID era we have seen that how they have helped us. So nasopharyngeal swabs, you can do individual PCR for individual infection when you are suspecting, or you can go for multiplex. There are panels, certain panels are available, upper respiratory panels, lower respiratory panels. Okay, but problem with panels is that it can detect the normal flora also, which is non-pathogenic. Okay, and then you get confused. So before ordering multiplex PCR, it is better to order individual PCRs for suspected infection rather than doing multiplex PCRs. If you're doing multiplex PCRs, then you will get the causative organism also, but you can get other viruses also, which are common flora in the nasopharyngeal area. Okay, so and our nasopharyngeal areas flora keeps on changing depending on seasonality, depending on the our immunity. So second thing is that if you are having low respiratory tract infection, and if you are doing upper respiratory panel, and if you try to correlate with the lower respiratory tract infection, it will be then it will have again problem, because it is not from the actual site of infection. If you're having pneumonia and like say lobar pneumonia, and if you are doing upper respiratory panel to find out what is the cause of that lobar pneumonia, then it is wrong. Okay, but definitely the upper respiratory panel, if you find certain viruses like a certain influenza virus, parainfluenza virus, human metapneumovirus, then rhinovirus, RSV virus. So if these viruses are present, definitely they are what you say causative. Okay. Other bacterial infections like Streptococcus pneumoniae, H influenza B. Okay, these if you find those also, definitely they are important organisms. Okay. Other than these viruses, other viruses are there which are common, which can be found, which can be common cells, which can be normal flora, but you have to be very cautious while correlating them with your disease. So if you are doing say for pneumonia purpose, don't go for upper respiratory panel. You have got separate lower respiratory panel for that. In those patients, you will have to go with the bronchoalveolar lavage or minibal if the child is intubated, and you will try to correlate with that. So upper respiratory panel, multiplex PCR probably should be avoided. For particular targeted PCRs, you can do. If you are suspecting flu, go for only H1N1 as such as so flu panel. If you are suspecting adeno, go for that PCR. So particular PCR will be more helpful. And if you are in a confusion, if you are in dilemma, you can send multiplex PCR, but you have to be very cautious to differentiate between what is the normal flora or what is non-pathogenic flora and pathogenic flora. So you should be very careful while interpreting that.
Right. So that is very good piece of information that you have given. Now, only one thing, many times our colleagues, who are at the periphery, like, suppose a pediatrician is practicing at a place like Bede, okay, or Parbhani, or, those areas. Now, obviously, they don't have the, access to this RT-PCR. So
Yes.
now, suppose there is a real problem for our colleague pediatrician and he wants to find out that fever has not gone down and respiratory symptoms are not coming down. So I want to send the swab, nasopharyngeal swab. So is it possible for him to send the swab from there in any way? That means transport of the nasopharyngeal swab rather from say one distant place like Bid or Parbani to Pune or to other place. Are there facilities now available in these peripheral areas also? Or
Yes, sir. Most of the labs are giving transport facility.
okay,
So if you coordinate with the lab, they give you transport facility, but the swab should be refrigerated and it should be transported at the earliest opportunity. So, but yes, if you correlate with your labs, and because nowadays more and more labs are reaching periphery, they are having collection centers at the periphery, they are having processing unit at one central place, and they are collecting samples from periphery. So, I think post COVID, most of the labs have equipped with the PCR instruments, because in COVID era, it was so rampant, it was so commonly done. So post COVID, most of the labs in periphery also are equipped for handling such specimens. And yes, you can send, you can correlate with them, and you can send those swabs definitely.
okay,
So I
that is
don't
very
think there is extreme, unless and until you don't have access to for a vehicle to go such
correct.
areas.
Correct.
Those areas are difficult. But where the transport facility is good, definitely with coordinating with your labs, you can send those swabs definitely.
Okay, that is very good. And then one last question, Kayur. I always, think, when our colleagues at the periphery, periphery means, where, the parents are, periphery doesn't mean only distance, but the chance
Yeah.
that the patient may not come back to our pediatrician colleague again, or, he has,
Mhm.
very less money. He says, no, I don't have that much money to come back. But now, Dr. Jog, Dr. Kayur, you are so reputed that I brought my child listening to your name. Okay, now I want that the child should be cured, isn't it? Every parent ultimately will say that the child should be fine within a short
Right,
period.
right.
So, it comes to my mind that, okay, let me start with amoxicillin. Let me also start with oseltamivir. Okay, give him paracetamol, give him some, treatment if there is some, bronchospasm. Let me give him some bronchodilator, some cough syrup. And usually this is how, things go on, and I'm sure in some parts of even cities like Pune, Mumbai also these things must be happening. So let us be practical. So the point is that how would you look at this situation? So is it possible for a pediatrician to be rational by not giving antibiotics in a viral infection child? Or something like that. So this particular question I have not yet found a proper answer. But how would you look at this scenario? As to how best rational we could be in a situation. So I know it's a difficult question, but I thought you must have given a thought as an
Okay, sir.
infectious disease specialist.
So when most of the infections in our OPD, as we all know, 90% are viral in origin.
Right.
Okay. So, of course, before prescribing antibiotic, you should think twice that whether this child really needs antibiotic or not. See, most common side effect with amoxicillin, people complain that it is diarrhea.
Right.
Okay. But I have never experienced diarrhea with amoxicillin. Very rarely, very rarely. Why people experience diarrhea with amoxicillin? Because they prescribe amoxicillin viral infections. That's why I experience diarrhea. Okay. So per se, if you prescribe drug properly in proper place, it will not have any problem. So just keep in mind that 90% of your OPD patients with upper respiratory tract infection will not require antibiotic. That is the clue. So while there's a 90% you will not. So if you are seeing 100 patients of upper respiratory tract, your prescription rate of writing antibiotic should be 10%. If it is more than that, you should just retrospect yourself whether I'm prescribing more, because this is general scenario all over. 90% will be viral, 10% will be bacterial. Okay. Again, we all know how viral infection present with a sudden high grade fever on day 1, 2 only with body ache. All viral prodromes are there as you have described it. So when viral prodrome is there, other mucosal involvement is there, high grade fever at a start only, then more likely viral infection. We all know this. But sometimes what happens in OPD, because we think that this child should not get to some another pediatrician, or if he's not feeling well, and then that fellow will say, no, antibiotic to likha hi nahi tha. I will write now antibiotic, you will get relief. Problem is that he gets relief not due to antibiotic, he gets relief because by the end he reaches second pediatrician. The 5 days already passed and the viral fever, the what a surge of fever is coming down. Okay, so you should be very confident and you should explain the patient very confidently. So look, this looks like viral infection because the fever is high grade and other prodromal symptoms are there. It doesn't need antibiotic because nowadays people also ask antibiotic. So antibiotic नहीं लिखा, antibiotic लिख दो, उससे आराम पड़ता है. Then you will have to counsel them properly. कि, look, this is viral infection. I think this is viral. Unnecessarily writing antibiotic will cause antibiotic resistance, and your child will suffer from that if he gets diarrhea due to antibiotic. So better to wait. You can, if you think child will not at all come for review, but I don't think it happens in our practices. We ask them, if your fever continues, then you come back. We will review again our diagnosis and we will go accordingly. Okay. But in periphery, I know people think ki wo to parat येणारच नाही तो. But if you think it is viral, high grade fever and everything, and it fits into category of WHO, you start antiviral. You can start straightway. You can start straightway antiviral. There is no problem. Antibiotic start. There is no hurry of starting antibiotic on day 1, 2, 3. He will not deteriorate because you have not started antibiotic on day 1, 2, 3. He will deteriorate if it is other problems other than. But bacterial infection on day 1, 2, 3 for upper respiratory, you have not started antibiotic and you think कि वो deteriorate हो जाएगा. He will not going to deteriorate. So what will happen is fever will not subside. He will have other tonsil exudates will be there, and so you will have better picture when he comes to follow. But for first visit on day 1, 2, 3, remember, just keep in mind that 90% are viral, 10% are bacterial. Am I justified to write antibiotic in this? And if you are strongly suspecting it is viral flu, don't hesitate to start oseltamivir, because as you have already said, it works best in 48 hours. So this is just the message.
Right. Thank you, Keyur. You have made the point very clear. And I always said that sneeze and wheeze are viral. Watery nose and watery diarrhea means viral. Okay, so our colleagues can remember that Keyur has also said that 90% of infections, whether respiratory or gastro also, they are all viral. So in general, the need for antibiotics is likely to be there only in 10%. Okay, so maybe from tomorrow onwards, our colleagues can start keeping a record of just a record of name of the patient and the treatment given, and they can find out, suppose if they are getting 100 patients in a day and then 90 are receiving antibiotics, then there is something which is going wrong, isn't it? So but only if 10 are receiving antibiotics, then probably you are going in a right way, and that's a very good message. So at least our people will control the use of antibiotics, and at the same time, if it's influenza season and child is having symptoms and signs suggestive of influenza, and there is somebody in the vicinity who is also unwell, and everything is favoring influenza clinically, then it is better that you put oseltamivir, start it as early as possible, and use your conscious. I always say that the prescription is written by the hand, but the decision should be taken by the head, and then it should come through the heart. The sequence is head, heart, and the hand. Okay, the heart, because antibiotics are not that cheap, and it costs a lot for the parents also. So use all these three H: the head, heart, and the hand, and that will probably guide you. And in addition, if there is any question anytime, please feel free to communicate to us. So with that, thank you, Keyur, for joining this particular group today. And Samruddhi, in case if there are any queries from our colleagues in the chat box, please feel free to ask. Otherwise, we can conclude the session.
Right, sir. Most of the queries are answered, sir. And
Thank
what a wonderful session. Therefore, on behalf of Hetero Healthcare, I extend my gratitude to all the doctors for participation, and I also thank both the speakers, Dr. Keyur Mahajan and Dr. Pramod Jog, for such an informative and interactive session. Thank you very much, sir.
Thank you. Thank you,
Thank you.
Samruddhi. Thank you, Keyur. So we'll meet at some other occasion. Thank you.
Yes. Sir is left. Right. Thank you, sir.